I know it's being a tough day and a tight scientific program, but being the chairman of the scientific committee أي حدا بده يسب إنه البرنامج كثير مزحوم يسب علي أنا. Let's start by thanking Novartis, all the people of Novartis, their partners and close friends of us, for their continuous support to the scientific activities of our society. And in fact, one of the most difficult tasks an internist can face, and almost on daily basis, is managing a diabetic and or a hypertensive patient, especially if associated with comorbidities, I mean renal problems or congestive heart failure or whatever. And the best to talk about those subjects, managing diabetes with comorbidities and managing hypertension with comorbidities are close friends of mine, actually. I'm very proud and privileged to introduce the first speaker, who's Dr. Nidal Khatib. Nidal is well known to all of you, and I think you know every bit of detail about Nidal, but I have to go by book by presenting him. Nidal is a consultant endocrinologist. He's a head of diabetes and endocrinology department in the Islamic Hospital, which is the largest private hospital in Jordan. He has French Board of Endocrinology and Metabolism, and he is a member of the American and European Endocrine Societies. Dr. Nidal Khatib.
Thank you, Mohammed, for this nice introduction. We thank you all. الصبايا بالإسلام طبعا. Also we thank Novartis. مش حد الكتار جماعة Novartis, but many thanks for this nice gathering, scientific gathering. Today I will talk about a case, a diabetic case with renal impairment. وبجوز احنا محظوظين انه our chairman is a nephrologist, he can help me to clarify some aspects, some points in this regard. So our diabetic patient, he is a little bit old, 65-year-old. His diabetes discovered for the first time in 2009 with the classical symptoms of the disease, polyuria, polydipsia, weight loss. Immediately he was started metformin. This metformin was up-titrated to reach the maximal allowed dose of 2 grams daily. And despite this, his blood sugar is not controlled. In 2010, his HbA1c was 9.5. So his treating physician decided to start a basal insulin analog, one of the analogs available in the market. Well, this insulin analog was titrated according to his fasting plasma glucose over 4 years. وصلنا تقريبا to 80 units of this long-acting insulin analog. Despite this, our patient is not comfortable. He is still complaining. بال2014, despite 80 units of this basal insulin and 2 grams of metformin, his HbA1c is still above the target, 8. Blood pressure started mainly systolic to raise a little bit, and the GFR was estimated at 48 ml. So we are dealing with a diabetic patient who developed mild renal impairment. كنتوا عارفين انه بس عندهم شوية kidney problems بجوز هنا his physician he didn't check his proteinuria, most likely حيكون proteinuria وحيصير عنده شوية ضغط يرفع فصار في عندنا this is a typical diabetic patient with diabetic nephropathy he is not controlled. So the question is, what's our next step as physician to control this patient? تعرفين which HbA1c target that patient is around below 7. This patient initially he is reluctant during his follow-ups. He is reluctant for many insulin injections. يعني حتى one single injection he was reluctant to take it. He was forced, let's say. What options do we have other than his current treatment to control his diabetes? So we have these options. I would like your idea, you have an idea, is one of the options is to add rapid-acting insulin before the main meal and to discontinue his metformin. Will it do the job? Will it bring down his HbA1c below 7? Another option is to add our new class, which is the di-glutidase-4 inhibitor, and reduce his current dose of metformin to 1 gram daily instead of 2 grams. The third option is to add a glucagon peptide 1 receptor agonist and keep his metformin current dose. The fourth option is to use, it is not available in Jordan, it is available in other countries now, this new class of anti-diabetic agent, the sodium glucose transporter 2 inhibitors. This is an option. Or to discontinue his current therapy and to shift the patient completely to insulin, meaning to insulinize this patient, give him a prefixed insulin, either PID or BID re-injections. Taking into consideration this patient is refusing multiple injections of insulin. This is the classical case which we face in our practice. أتصور الكل يعني متفقين بيجينا معنا أن مريض عنده diabetes not controlled. Once we يعني pronounce insulin بتبلش المعارك والخطاط والكذا وما بدي انسولين وما بدي مش عارف ايش وهذا بالنسبه له it's the end of his life وانه يعني what do you choose as option among these 5 options in order to control this patient, this particular patient, provided not to harm his kidneys? ما في عندنا voting ما في voting anyway, I would like to hear from you. Dr. Samir مع option number 2, adding the inhibitor and reduce the form to 1 gram daily. Anybody with? Anybody against?
Yes, I agree with him. Number 2, I think is the best choice for him. If we take in consideration the age of the patient and the GBR of the patient.
Any other options? Any other? Number 4. Number 4 is a good option. But احنا قلنا in our case this patient is ما بده ياخذ insulin, ما بده multiple insulin injections. It's a good choice to control the patient. الدكتور بتقول no GFR metformin is safe. That's true. Yes.
Below 60 creatine clearance, metformin relative contraindication.
We'll go for this. We'll show you new data about metformin and the renal impairment. There's a new coming data.
Below 30 it's absolute, but below 60
Okay, Doctor, we have some slides for metformin therapy in those patients with renal impairment. في new data. Any other options, any other opinions?
I would just say one, because he has medium renal impairment function, 1.7 creatine. And this means that metformin is not the recommended, or should the first
Just to give you an idea, a diabetic patient with HbA1c of 8, it means that his fasting plasma glucose is controlled by the long-acting insulin he's taking. And his problem, mainly postprandial glucose control. So once there is, let's say, an older study, once you reach an HbA1c between 7.5 and 8.5, this by default means that the fasting plasma glucose of your patient is controlled, and the problem now comes to the postprandial glucose to be controlled. Just keep this notion in mind. So, ما في general agreement.
option 6. Number 6.
تفضل دكتور.
Although number 2 may be a good option, I think also number 3 is not forced to it, especially we have now the once weekly GLP-1 like Victoza. So this one is also an injection once weekly.
So the doctor, he proposed the third option to start a GLP-1 analog. Patient is having renal impairment. GLP analogs, are they completely safe in such a patient? Anyway, maybe I will go for choice number 2, and I will show you some data that by doing so, you will control this patient without doing any harm to his kidney function. As you know, renal impairment in diabetics is very common. It's a very common disease. Around 30 to 35 diabetics, they will develop after years diabetic nephropathy. So it is common. It is a common problem that we face on a daily basis. And this problem, per se, limits our therapeutic options in terms of 2 things. Drugs, as said Dr. Leonard, and the metformin, it was an absolute contraindication in patients with renal impairment. Nowadays, we have new data that it is a relative contraindication provided the degree of GFR, according to the GFR. Sulfurias, they are either contraindicated or you have to reduce their dose to the minimum because of risk. The hypoglycemia, salt in a salt is very common, salt water. DCDs انتوا عارفين الاشكاليه مع although they are safe للناس اللي عندهم impairment، لكن موضوع الفلويد ريتنشن، موضوع الصوت ريتنشن، وهدول الناس already بيكون في عندهم fluid overload، ف you will increase the problem. Even insulin, a patient with renal impairment, insulin clearance is unpredictable. So there is increased risk of hypos and hypers لأنه الموضوع الانسولين كليرانس is really affected. هي شغلة، الشغلة الثانية الدايابيتكس اللي عندهم renal impairment, their blood sugar fluctuate widely through the 24 hours. وشغلة مهمة جدا ال HbA1c that we ask for those patients is not always correct. Most of the time, because of his problem, kidney problem, is false positive results. We call it HbA1c. Renal impairment is a common disorder among diabetic patients. طيب, how we estimate the kidney function? هلا كثير physicians they depend on the serum creatinine, serum urea. I think the best way, maybe Dr. Muhammad will agree with me, and to estimate the GFR. The GFR should be estimated from prediction equations that take into consideration serum creatinine concentration, age of the patient, gender, his race, and body size. وفي عندنا two يعني well-known formulas, the modification of that in renal disease, or the Cockcroft equation. Really, by estimating the GFR, you have the best overall indices of the level of kidney function. بالنسبة للكوكروف equation بتصور كلكم familiar معها، أنا حبيت بس refresh your memory من ناحية physiology. It estimates creatinine clearance based on serum creatinine, because creatinine is not only filtered by the glomeruli but also secreted by the tubules. The Cockcroft equation tends to overestimate the GFR, since it measures the GFR plus creatinine excretion through these tubules. So the inclusion of a weight coefficient in the equation causes also a GFR overestimation in the presence of that and the less random spleen or random edema. It is a less balanced equation and more accurate, a GFR of 60 to 20, 120 ml per minute per 1.73 millimeters square than the other formula that I think تستعملوا تستعملوا which equation, by which equation you estimate GFR? What do you prefer? First one or this one? This one is more easier. The middle equation, you just, it's the most accurate estimate of GFR. It's only based on serum creatinine. It considers age, sex, race, and does not require a body weight variable, because it normalizes GFR for a standard body surface area of 1.73 meters square. This equation wasn't tested or has not been tested in children, in elderly more than 75, and in pregnant women, those with big muscles. Like grosso modo, this is one of the best equations to measure the GFR. هلا عندنا classification. Yes.
I want to ask, when we look at this equation, they depend on the serum creatinine. And serum creatinine, when we look at these equations, they depend on serum creatinine. And serum creatinine is related to the muscle mass. And some of these patients have low muscle mass, and you have false reading. disability does not affect group 1. So usually GFR does not also be right.
I think we leave the comments and questions
Okay.
to the end of this session, but that's why it's called estimated glomerular filtration rate, because the most accurate method of assessing kidney function is to measure the glomerular filtration rate. So measure GFR and not estimate it. So it's an estimate.
So we'll go for rapid classification of kidney chronic disease. We have 5 stages. Stage 1, kidney damage, يعني في عندنا structural changes بالداخل diabetics بيكون عندهم thick basement membrane وبيكون عندهم in the beginning high GFR. شايفين انتم stage 2 بيكون كمان في عندنا kidney damage, GFR start to decline. Third stage اللي هي moderate chronic kidney disease, كمان GFR is declining more and more between 30 and 59. Stage 4, severe decline in the GFR between 15 and 29. Of course, stage 5 is kidney failure, they need dialysis. GFR below 15. So, to answer your question, Doctora, metformin was contraindicated in patients with any degree of chronic renal disease. لكن في عندنا نيو هلا about the use of metformin in patients with different degrees of chronic kidney disease. So if your GFR above 60, you can use metformin freely by any dose that you like. If the GFR below 60 and above 45, which is the case of our patient, you can continue the use of metformin, but you have to increase to monitor more frequently the kidney function every 3 to 6 months. If the GFR below 40 and above 30, you have to lower the current dose of your patient, metformin dose, to 50%. Of course, below 30 GFR, metformin is absolutely contraindicated and should be stopped. And this is a habit of slide هذا. It can be used by patient اللي عندهم mild to moderate chronic kidney disease. Now we'll talk about the other drug, which is vildagliptin and renal impairment. We have, this is a new study, a recent study, to show that this drug is safe and effective. Safety comes before efficacy in patients with moderate or severe renal impairment. This study was a multi-center randomized, double-blind clinical trial to evaluate, first of all, the safety and tolerability, 24 weeks treatment with vildagliptin, 50 mg daily versus placebo in patients with type 2 diabetes and moderate or severe renal impairment. This is the objective and the study design. So the primary objective of the study was to evaluate the safety of the drug in patients with renal impairment versus placebo as monotherapy or added to other anti-diabetic drugs the patients are taking. Other study endpoints to evaluate the efficacy, the effect on the HbA1c, the effect on the fasting plasma glucose in the group of vildagliptin compared to the placebo. So this is the design. Patients, they were divided in 2 groups. The first group was started on vildagliptin 50 mg daily plus their current therapy. The other group was kept on the same current therapy and added placebo on top of their current therapy. The duration was 24 weeks blind treatment. These are the baseline characteristics of the patient. بهالدراسة هاي المميز فيها أخذوا ناس كبار بالعمر more than 75 years شايفين تقريبا عدد المرضى كان بالفيلداجليبتين 165 مريض حوالي يعني 27% كان أكثر 25 سنة. الHbA1c أو المين HbA1c كان around 8 بهالدراسة هاي. المين duration of diabetes around 15 years. يعني كثير مهم إنه أخذوا ناس كبار بالعمر which is not the case in other studies. With duration of diabetes is a long duration. البيشنت بالدراسة هاي معظمهم كانوا ياخذوا انسولين مونوثيرابي. حوالي 57% of the patient they were on insulin monotherapy. كمان في عدد كويس كان على SUs monotherapy 21%. في كانوا ناس ياخذوا combination three drugs which is unusual in such case لكن موجودين حوالي 4% تقريبا مرضى. طيب شو فرجانا these are the results. شايفين هذه الفيلداجليبتين كومبير للبلاسيبو. هنا الفيلداجليبتين وهنا البلاسيبو. شايفين في عندنا كان significant احنا drop in HbA1c in the vildagliptin group compared to the placebo, minus 0.4 compared to only 0.2. Between treatment difference can very significant 0.5 in favor of vildagliptin. هذول الناس اللي عندهم motor impairment، الناس عندهم severe renal impairment, you will get with vildagliptin a good reduction in HbA1c around 0.9% compared to only 0.3% in the placebo group. Between treatment difference can كمان significant 0.5. Vildagliptin in such patient will significantly reduce HbA1c by around 1%, which is not that bad. If we take patients who are considered to be responders and divided them according to the degree of HbA1c, شايفين in the vildagliptin, the patient at the end of the study, they achieved HbA1c below 6.5, كانوا around 20% compared to 2% in the placebo group. Those who achieved HbA1c 7 below 7, كانوا 30% compared to 24% in the placebo group, which is our target force. الناس اللي they achieved HbA1c below 7 كانوا أكثر بالفيلداgliptin group 7.5. In those with severe impairment, also you will get significant results in the vildagliptin group compared to the placebo group with different degrees of HbA1c. Now we are not aiming at such strict HbA1c below 6.5. And now our aim to bring down the HbA1c of our patient below 7. هلا إذا أخذنا الناس اللي هم كانوا more than 65 years and younger وشفنا الدروب أو الريدكشن للHbA1c راح نشوف إنه كان كمان very significant مع الفيلدا compared للبلاسيبو. هذول اللي هم بيعتبروهم بعض young below 65 بس اللي بيعتبروهم old. And both below 65 and above 65, the drug was very effective compared to the placebo. Even those with severe impairment, the drug was effective in patients below 65 years and patients above 65 years compared to the placebo. شايفين around 0.9 reduction in HbA1c, which is a good result. إذا أخذنا the study provided greater reduction in HbA1c versus placebo with low and high baseline HbA1c. هنا according to baseline HbA1c, so again baseline between 7, you will get a good result. Between 8.7 and 8.7, you will get an excellent result in those with severe impairment, regardless of the baseline HbA1c, 7 or 8.9, around 9, you will get an excellent result. So even with those with high baseline HbA1c, you will get a very significant result with vildagliptin compared to placebo. إذا أخذنا الشيء اللي يهمنا إحنا زي ما حكينا إنه any drug, your patient, very fragile patient. So when you think of using a drug, you should not harm the patient. You should not harm his kidneys. وزي ما شايفين هون الفيداجليبتين its safety was very similar to the placebo in terms of any adverse events. ما كان في أي difference between the placebo and the vildagliptin. إذا أخذنا الهايبركاليميا as adverse events, كمان ما كان في أي difference between the vildagliptin group, placebo, and those with moderate or severe renal impairment. The change in potassium was almost negligible with vildagliptin. إذا أخذنا اللي هو صار شرط لكم الانسيدنس of hypoglycemia in both groups, there wasn't any significant increase in the incidence of hypoglycemia in the vildagliptin compared to the placebo. And what about the cardiovascular effects? Also, إذا أخذنا many cardiovascular endpoints, coronary syndromes, arrhythmias, congestive heart failure, death, strokes, you can see there is no difference between the placebo and the moderate or severe, between the placebo and vildagliptin. So you have a safe drug, it acts like placebo. And in terms of safety, not in terms of efficacy. اللي بيهمنا كمان موضوع الكدني function. When using vildagliptin, this will deteriorate, this will harm your kidneys. You can see clearly that this is the baseline GFR in both groups, the vilda and placebo. And this is the mean change from baseline. You can see there is no effect or harmful effect. There is no deterioration in the GFR during this trial. سواء عند الناس عندهم moderate or severe renal impairment. Other خلينا نقول side effects like edemas, hepatic disorders, muscle disorders, infection, pancreatitis. هي بهالدراسة هاي there is no single case pancreatitis. تعرفين إنه دي فورمات كانوا كثير يحكوا عن موضوع pancreatitis. There is no single case registered in this study of pancreatitis, لا بالبلاسيبو ولا بالفيلداجلبتين. Thank you very much for your attention.
Thank you, Mr. Nadal, for the nice case and presentation, and we'll take 2 short comments or questions. Salat.
Solid number about the serum creatinine with using metformin. That is, don't use metformin in serum creatinine more than your figures, because the rule is not to make in our well.
الدكتور حسن ما سمعتوه كويس. احنا كان all teaching ruled not to use metformin is contraindicated in males with serum creatinine of 1.4 and females with serum creatinine 1.3. Like, as I mentioned, serum creatinine alone, the concentration creatinine, does not reflect or give us a good idea about the kidney function. So the best thing to estimate the GFR, I don't know if Dr. Mohammed agree with me or not. Dr. Mohammed, can you highlight this problem, the difference between, because they depend mainly on the serum creatinine to evaluate the kidney function.
Serum creatinine is a rough estimate of kidney function, and we depend definitely on measured glomerular filtration rate rather than estimated glomerular filtration rate. As Nidal said, there is no absolute contraindication above a GFR of 30 for the use of metformin. The only fear in the past was lactic acidosis, and actually we've seen a case of lactic acidosis almost every 4 or 5 years, so we do not see it. So there is no contraindication for the use of metformin above a glomerular filtration rate of 30.
So this was the Samanion. This was one of the aim to present this case. Metformin can be used in patients with a chronic kidney disease, provided estimating their GFR. With, of course, we should closely monitor their GFR. But it can be used. There's no more contraindication. Any other questions?
Yes, please.
Last one, please.
The question is, what about the use of other NBD4 inhibitors in renal impairment? About the safety? Has the same safety and efficacy and the
I showed you a safety and efficacy trial, which was done recently on beta-gluten, the 50 milligram, so it's safe and effective. We have other glutens. Saxagliptin is safe with a dose of 2.5 milligrams and effective. Sitagliptin is safe with a dose of 50 milligrams. So the other gliptins, let's say even linagliptin, is safe to be used in patients with renal impairment.
So one last question, please.
Sometimes you come across cases of normal serum creatinine with high blood urea nitrogen. Is that caused by furosemide treatment or other causes? Thank you.
I think I will refer this question to Dr. Mohammed.
Thank you. As I said earlier, normal serum creatinine does not mean normal kidney function. So glomerular filtration rate, please, not serum creatinine, but the process of high urea with normal kidney function or dehydration is number one, as you said, due whatever cause. GI bleeding is number two, drugs number three. So there are a lot of causes of high urea with normal renal function. So Dr. Nidal, thank you very much, and we have to move to our next speaker.
Thank you very much. Thank you.
Thank you.